And now it is my task to discuss briefly the new treatment guidelines that came out of Nice. This happened in the latest World Symposium on Pulmonary Hypertension in February 2013. The document that was produced was published in JACC in December last year. And of course, it's an extensive document, and we'll just touch upon 3 key points. And throughout the talk also, I will try to add some data that did not make it into the Nice publication because it happened after the meeting. And then we'll take a brief look at what future guidelines may look like. So this is the upper part of the treatment algorithm. And as before, it starts by emphasizing general measures. And the Nice document didn't really address or comment on major changes here. We'll talk a little bit about some new information about anticoagulation. And the other general recommendations are pretty much unchanged. I will just point to this 1A recommendation to supervise exercise training, 1A being the highest degree of recommendation that the committee felt could be given. And this reflects the fact that over the last few years, there is new randomized controlled trials that have been published documenting the safety and efficacy of a supervised exercise program in patients with PAH. And certainly we have incorporated that into our practice. The expert referral remains there, and we certainly advocate for that. There is a need for patients to be at least initially evaluated by an expert pulmonary hypertension center, while recognizing the tremendous importance of local and community doctors in maintaining the optimal care of these patients. But at least for the original evaluation, it remains highly recommended that patients get referred to an expert center. Neil alluded to the acute vasoreactivity testing, which is strongly recommended for those with idiopathic pulmonary arterial hypertension, a weaker recommendation for other forms of PAH, simply due to the fact that true vasoreactivity is extremely rare in other types of PH. He gave you the vasoreactive definition, and he told you that those who are vasoreactive can be treated with calcium channel blockers. But one needs to be careful because we know that at least half of those patients that were originally vasoreactive and successfully treated with calcium channel blockers will deteriorate over time, meaning they will become more symptomatic. And those who do that, then they need newer PAH-targeted therapies, just like those who are non-vasoreactive from the beginning. This slide shows you data from the Compera registry, a European-based multicenter registry of newly diagnosed PAH patients, and they look at the survival of those patients who were anticoagulated versus those who didn't. And you can see there is apparently a survival advantage in those with idiopathic PAH. And unpublished, recently presented data suggests that could be extended to those with drug-induced and heritable disease as well, although the numbers were much smaller. However, in those with associated forms of PAH, there was no survival advantage. So it is our practice that, barring any obvious contraindications for those with idiopathic disease, anticoagulation is indicated until we have a randomized controlled trial, which unfortunately is unlikely to be done for various reasons. But now moving on to PH-targeted therapies. Then I will show the treatment algorithm for pulmonary hypertension that came out of Nice. And I will highlight 2 things here. There are 2 new drugs that were not in the previous algorithm. One is macitentan, and the other one is riociguat. The rest of the drugs were there. But the second thing that stands out, of course, is that there are 2 drugs that are yellow out. And they're yellow out because the committee felt that there was a morbidity and mortality as primary endpoint study, or there was reduction in all-cause mortality prospectively defined. And so the Nice committee felt that only ipoprostenol or macitentan fit that bill. And let's examine that claim more carefully. So this is the data for ipoprostenol, a famous study published in the mid-90s, 80 people with severe PAH Half of them randomized to epoprostenol. The other half received conventional background therapy, which back then was pretty much anticoagulation, diuretics, oxygen, and digoxin. Nobody that received epoprostenol died, and substantial mortality over a 12-week period in those with conventional therapy. So the right answer is intravenous epoprostenol is the one type of drug that has been shown to decrease mortality in PAH, and I hope that perhaps will be the main take-home point of this talk. Now, let's examine the data for macitentan. This is a time to mortality graph, and you see that in orange, those that were randomized to macitentan 10 milligrams, and in yellow, those that received placebo. And as you can see, there is clearly a separation of the curves, but this was not a statistically significant result with a hazard ratio that was as low as 0.29 and as high as 1.42. So this means that if you were to do this study 100 times, 95 of those studies will come out with a hazard ratio that will be between 0.29 and 1.42. So you really cannot be sure whether or not macitentan truly improves mortality. What about morbidity and mortality? So if you add other endpoints besides mortality, and I'll show you what those endpoints were. And this is a flip curve, so this is the patients without an event. And now you can again see that those that received 10 milligrams of macitentan did much better, meaning had a much lesser probability of a clinical event over the time of follow-up, and this result was indeed statistically significant. So certainly you can say that macitentan was successful in preventing morbidity and mortality, but what are we talking specifically about this? So the composite endpoint on that trial was death from any cause, initiation of prostanoid, lung transplant or atrial septostomy, and worsening of PAH. And it turns out that actually worsening of PAH accounted for the vast majority of these events and certainly accounted for the difference. What was the definition of worsening PAH? It was a composite of these three things, and you need to have the three of them to qualify as worsening PAH. Decrease in 6-minute walk distance, worsening PAH symptoms, or appearance of right heart failure, and the need for additional PAH treatments. So this is what the data show. So there is a clinical event prevention with macitentan therapy, but was mostly driven by this particular endpoint. And so this type of composite endpoint has been used in previous studies, but of course the main difference was that the macitentan trial was actually a first and very, very important trial, first in its kind. The first trial that was not powered to a primary endpoint of 6-minute walk distance, but primary endpoint was this time to clinical worsening. And in doing so, it allowed us to test the drug over a long period of time. Median exposure in this study was 2.2 years. So we do have actually significant clinical efficacy over a long period of time for macitentan in a first-of-a-kind clinical trial. But that being said, of course, time to clinical worsening has been tested in a number of other pivotal clinical trials during a 12 to 16-week period. And as you can see, one of the challenges is that the different elements that went into this composite endpoint are not uniformly distributed across the clinical trials. All of them use death and hospitalization except the macitentan trial, but variably they included lung transplant, atrial septostomy, and some sense of symptomatic worsening, and most of them included the need for additional PAH therapies. And so, for example, bosentan show benefits here, ambrisentan, tadalafil, the addition of iloprost to background bosentan, tadalafil therapy, the addition of sildenafil to background IV epoprostenol, and a more recent trial in Heresi. So all of these studies also show some improvements in time to clinical worsening, only in a shorter span of time. This is the other new kid on the block, Heresi. And this was tested as in a more traditional clinical trial, 12-week duration. Primary endpoint was 6-minute walk distance. We are unlikely to see clinical trials like this anymore. I think the future is similar to the macitentan trial, longer-term, event-driven studies. But Heresi was effective in improving the walk distance compared to placebo, effect size of about 36 meters. And again, as before, it did delay the time to clinical worsening, but similar to other drugs, this was due to hospitalization, additional pH therapies, and preventing worsening of 6-minute walk distance. So no really mortality benefit. So the take-home point is that, yes, we do have new effective medications, but the one that has been proven to decrease mortality is intravenous epoprostenol. Oral treprostinil didn't make it into the NICE guidelines. This is data published afterwards. And now it is FDA approved and is currently commercially available based on the data shown here. This is oral treprostinil monotherapy compared to placebo. And in a 12-week trial, it did show an improvement in the 6-minute walk distance that met its primary efficacy endpoint. However, the effect size seems a bit low, 20 meters. And then also disappointingly, in another trial where oral treprostinil was added to background therapy, actually it was not effective. It did not meet its primary efficacy endpoint. And this was different, for example, than the macitentan and the Heresi trials that included a sizable proportion of background therapy and yet still were able to show efficacy. So a bit disappointing results with oral treprostinil, although some experts with a lot of experience with the drug claim that if you're able to push the dose high, it's actually rather effective. Unfortunately, GI side effects limit the dose titration of this medication. But it is commercially available, did not make it into the NICE guidelines, it's probably going to make it into future guidelines. And so this brings us to the 12 medications that we currently have available to treat PAH and includes 4 different pathways. Endothelin blockers, with these listed here, PDE5 inhibitors, a new pathway, soluble 1-LA cyclase stimulator, that is Heresi, still within the nitric oxide pathway, but a different mechanism of action, and prostacyclin. And prostacyclin is actually now, in the form of treprostinil, run the gamut of oral therapy, inhaled therapy, and parenteral therapy. Iloprost also is an inhaled therapy, and of course, epoprostenol, both the traditional original formulation and the room temperature stable formulation. So the question is, how do we choose among these 12 medications? And certainly, while the guidelines stratify the decision-making based on the functional class, a more sensible, practical approach is to not only consider the functional class, but take into account other parameters that will put your patient into a low-risk or a high-risk category. And then if you conclude that the patient is low risk, you're probably good enough with an oral therapy, at least to begin with. But if your patient falls into a higher risk category, you should consider strongly starting intravenous epoprostenol or parenteral prostacyclin therapy. Now, the question is, how do we know whether somebody is low risk versus high risk? And unfortunately, we have reasonable amount of data to at least have some insight into that question. There are established risk predictors that have been gathered based on observational studies and large registry data. Some of these factors are non-modifiable, for example, male gender and older age. Of course, there's nothing we can do about that. We know about certain etiologies of pulmonary hypertension that are associated with worse prognosis, specifically connective tissue disease, heritable PAH, and portopulmonary hypertension. But then there are certain factors that luckily we can, or at least attempt to modify. So somebody with a higher functional class, 3 or 4, a lower 6-minute walk distance will be considered increased risk. Very elevated levels of natriuretic peptides also confer a worse prognosis. Neil told you about the echo parameters, particularly the presence of pericardial effusion is a marker of bad prognosis. Some functional status of the lung, particularly a depressed diffusion capacity for carbon monoxide, is a particularly good prognosticator as well. And perhaps most importantly, we've talked about hemodynamics a lot. Of course, those with evidence of right ventricular failure, those patients with an elevated right atrial pressure, a depressed cardiac index, those tend to do worse over time, and certainly they would fit the bill of an increased risk. So if your patient has most or several of these factors, then you would consider that patient at increased risk, and then you are very likely to start intravenous or parenteral prostacyclin therapy. Somebody who fits most of these criteria, you are likely to be comfortable starting an oral medication. We really cannot make comparative efficacy claims for oral PAH therapies. And the reason is that the only real way to do that, to answer that question, is to have a head-to-head trial comparing one medication against the other one, and that hasn't happened yet. And so if you try to analyze each study and try to come up with a conclusion as to which oral therapy is better than the other one, then you will run into trouble. The patient populations were very different. Earlier studies included more severe patients. Later studies included perhaps less functionally compromised patients. Trial design was different duration. I showed you already some discrepancies in terms of what the time to clinical worsening endpoint looked like. Long-term data that all of these medicines have is actually from open-label extensions that allow the addition of other therapies. So past the 12 to 16-week randomized phase, you really cannot make any other assumptions. Now, this is not true, of course, for macitentan. Again, macitentan does have a longer-term follow-up, and future trials, I think, will follow the same pattern. But the bottom line is that there's really no best oral PAH targeted therapy. And so how do we choose? Well, we choose based on a number of things. Again, we discuss oral parenteral based basically on the risk of the patient. But again, that's not in isolation. So you need to be mindful of other factors. For example, is this patient going to be able to handle complex therapies such as continuous intravenous infusion? Does the patient have the psychosocial support to be able to do that? Is he willing to do that? So some patients simply are not interested or willing to get a catheter and carry a pump. We talk about drug efficacy, and we talk a little bit about the randomized controlled trial data. But then also you need to follow and talk about what experience is, your own experience, experience of other doctors. Certainly, we all have our own biases and experiences. And then finally, tolerability and safety, drug and drug interactions, compliance. Certain medications are given 3 times a day. There's once-a-day medications that can certainly improve compliance. Adverse effects, background comorbidities may perhaps steer you one way versus the other one. So it is really a complex decision-making, which is why also, again, expert referral is recommended, not so much because, expert centers have a particular magical approach to this. It's simply because it does require time, expertise, and experience to come up with a reasonable best treatment plan. But whatever you choose to start with, then, of course, you need to monitor the effect of the therapy. And so the NICE algorithm will tell you to assess for inadequate clinical response, and we'll define that shortly. If you conclude that you have an inadequate clinical response, the guidelines recommend sequential combination therapy. And so, if you started with an ERA, then you could consider adding a prostanoid or a PD-5 or a soluble 1L cyclase stimulator. The key here is that these two cannot be combined. So if you start a PD-5, you cannot add riociguat and vice versa. But other than that, you can do sequential combination, double or triple combination therapy. And again, if you continue to be inadequate, that's when a referral for lung transplantation would be indicated. So how do we define adequate clinical response? That pretty much speaks of a proper right ventricular status, and we gain an understanding of that when the patient has a good functional class, 1 or 2, no more than 2, certainly. When he or she has a good 6-minute walk distance, certainly in excess of 500 meters. When you've been able to normalize or at least lower significantly BNP or NT-proBNP. The absence of pericardial effusion, TAPSE more than 2 centimeters. And again, very importantly, hemodynamic goals, right atrial pressure less than 8, cardiac index more than 2.5. So if we're able to sort of normalize or at least maximize all of these parameters to the best of our abilities, then you would conclude that you have an adequate clinical response with whatever therapy you're using, and then you should just carry on. But of course, the complete opposite is true. So you have a functional class that's worse or getting worse, 3 or 4. If your walk is not able to come up higher than 300 meters, if you have an elevated, persistently elevated or rising natriuretic peptide, if you now develop a effusion, if your TAPS is below 1.5, and certainly if your hemodynamics are worrisome, right atrial pressure more than 15, cardiac index less than 2, this is a patient who has overt right heart failure, and this is a patient that will need to be started on parenteral prostacyclin or certainly started on combination therapy if you already are on prostacyclin therapy. Now, regarding combination therapy, that's a whole topic on its own, but I'll just show you what I think are the perhaps 3 most important studies showing benefits of combination therapy. The first one is the PACES study. This was sildenafil on top of background epoprostenol, and this study actually showed significant benefits in terms of exercise tolerance, hemodynamics, and clinical worsening. And as I alluded to briefly already, these 2 new guys, the clinical trials actually showed significant benefits as add-on combination therapy. The Heresi pivotal trial had about half of them on background ERA, and the macitentan pivotal trial had actually 60% of those patients that enrolled into that study were on background PDE5, and 5% were on oral inhaled prostacyclin. And in those 2 subgroups, macitentan and Heresi actually were effective. So I think that these data are pretty good for add-on combination therapy for these new medications. And then just briefly, a peek at what future guidelines may look like. I'll just show you 2 things. This is hot off the press. This is not published. This data have been presented in abstract form in recent studies. This is the AMBITION trial. This trial tested the question as to whether or not upfront combination therapy was a better strategy than sequential add-on combination therapy. And so this study had 3 arms: upfront combination of ambrisentan and tadalafil, and was compared to monotherapy ambrisentan, monotherapy tadalafil. And the comparison is the upfront combination versus the pool monotherapy arm. The primary endpoint, again, was time to clinical failure, composite endpoint. This is, again, an event-driven trial, long-term. And so far, at least preliminary, this is unpublished data. This study was successful, a significant reduction in the composite endpoint, again, driven by hospitalizations. But perhaps not surprisingly, those people who were randomized to upfront combination therapy did have more side effects. So pending the publication of this data, this is likely to be incorporated into future guidelines, and it is potentially a paradigm shift, because the reality is that most of our patients end up on combination therapy sometime sooner or later, and it's likely that we are going to be looking more as the left heart failure field, where perhaps starting a combination of drugs for these patients may be the right way to go. The other thing that's pretty exciting that's probably coming is this ability to infuse intravenous treprostinil via an implantable pump and via a catheter that's tunneled subcutaneously into the superior vena cava. This has been tested, and the data is under revision. The pump actually is already commercially available and used for other things like baclofen infusions or chronic pain medicine infusion. The catheter is what's different, and at least preliminary communications from the investigators it seems to suggest that this is a pretty useful and highly well received by patients, because of course you remove the need for mixing medicines and pumps and catheters sticking out of your chest. So this is under revision. It's likely coming and likely to be incorporated into future guidelines. So to conclude, again, do not forget about general measures and the referral to expert center. I hope I show you that risk stratification is key in regards to making your treatment decisions. Again, no clear data to suggest best oral therapy, but I think we're learning that better longer-term clinical trials are the way to go to move the field forward. And I'm glad I had this here based on the previous response. Don't forget that parenteral prostacyclin remains the most effective therapy in spite of all the new drugs. And this is particularly important because we do have data that I didn't show that patients with PH who are dying, a large proportion of those are not on intravenous prostacyclin when they die. So I think that is very important. And with that, I'll end, and I'll be happy to take any questions.